Now to talk about the European Leukemia Net and real-world treatment algorithm for myeloproliferative neoplasm. I would say starting from polycythemia vera, starting from the diagnostic criteria, you know that the WHO publication in 2016 has established a very simple and a basic way to perform a diagnosis of polycythemia vera, which is based mainly in our days on the detection of the JAK2 mutations, both the classical mutation as well as the exon 12 mutation. Concerning the bone marrow biopsy, which is recommended by European Leukemia Net in all myeloproliferative neoplasm, it's said that it should be done in all cases, with the exception of cases with a high hemoglobin level or high hematocrit in polycythemia vera. But I would say that it's probably worthy to do it in all cases, even because in overt polycythemia vera, you may see that some degree of fibrosis can indeed tell us that there is an increased risk, although not so much, but an increased risk of progression of the disease towards myelofibrosis or acute leukemia. We know that it's possible to establish a scoring system for the patients with polycythemia vera, which are mainly based on two parameters. The first one is the age, which is playing a major role, as well as the presence of previous thrombotic event. And you may see that the difference, according to this scoring system in survival, is really big. And it may change indeed. It is mainly related, however, to the age of the patients. And so, as the polycythemia vera patients have a lot of symptoms that I'm not listing here, but it's itching as well as other types, sweating, and sometimes problems related also to the splenomegaly and so on. I would say that the current management of polycythemia vera is directed to prevent thrombosis and bleeding, which is the major risk, to minimize the transformation to myelofibrosis or leukemia, and to control the disease-related symptoms, which is also an important part of the treatment of this disease. And these are the polycythemia vera 2018 European Leukemia Net recommendation. The phlebotomy should aim to maintain a hematocrit level below 45% and to be associated with a daily assumption of low-dose aspirin. And the site reduction is still, I would say, recommended in high-risk patients, on patients with a hyper-myeloproliferative states, so high red blood cell count and so on, and for those who are poorly tolerant to phlebotomy or not responding to phlebotomy. And as first-line therapy, there are two main drugs which are recommended, which are classical hydroxyurea or recombinant interferon alpha. Ruxolitinib is recommended together with the interferon alpha again, are appropriate as second-line therapy for patients who are intolerant or do not adequately respond to hydroxyurea. So the reason, the basis for these recommendations are in data which have been published in the literature. Here is the paper stating that indeed to be or to remain with an hematocrit less than 45% is definitely better than remaining at higher level between 45 and 50%. And you see that is associated a lower hematocrit with event-free survival, which is definitely better. And the usefulness of interferon therapy has been quite recently proven by in particular by this study, which is the PROUD polycythemia vera, which was in origin a non-inferiority study, just to compare hydroxyurea versus slow-release pegylated interferon in patients who were or naive or with a short period of treatment. And the patients were randomized to receive one or the other. there was indeed a combination of almost two different studies. One is the proud polycythemia vera, and the other one is the continuation polycythemia vera. But looking at the first data after the first 24 months, you may see that indeed, although hydroxyurea is providing an immediate response to the patients with the achievement of a good response, but then it remains stable, and it tends little by little to decline. Interferon is able little by little to improve the results, catching up finally hydroxyurea, and after 2 years you may see that there are clearly advantages of being treated with interferon. And what is particularly relevant is the fact that even from the molecular point of view, interferon is able to produce a reduction of the allelic burden of the JAK2 positive clone, and this is not observed, of course, with hydroxyurea. Now we have in 15% of cases of polycythemia vera in which there is intolerance or resistance to treatment with hydroxyurea. And should we treat these patients? These patients have definitely some higher risk of progression towards myelofibrosis or acute leukemia. They may also progress, in particularly to myelofibrosis, if they are showing splenomegaly. And we know that we have two lines of therapy which can be used in these cases. One is again the pegylated interferon. And you may see that the red bars are corresponding to the polycythemia vera. There is, in terms of partial and complete remission, and an overall response which is quite good, achieving approximately 60% of the cases. And that this is similar to what you can observe in these cases if they are classified as thrombocythemia, essential thrombocythemia. But we know that in these cases, indeed, the Ruxolitinib may be the choice, because you may see here that in the response study, there is a clear advantage in terms of reduction of the spleen volume, as well as the control of the hematocrit between Ruxolitinib as well versus the best available therapy. And in the response to study, again, what is extremely important is that this therapy is also useful for those patients who were intolerant to previous interferon therapy. The patients who have reached a good response generally tend to maintain this response for a quite long period of time. As you may see, after 4 years, approximately 70% of the patients are still maintaining the response, and this is a good, of course, aspects. And therefore, Ruxolitinib, in particular for these patients, is showed definitely versus the best available therapy, even in patients who received interferon before. An advantage is showing also an advantage during versus interferon as second-line therapy directly in a randomized trial. And also patients who are failing interferon, therefore, can be moved to a third-line therapy if you want with Ruxolitinib. Now, what about essential thrombocythemia? The recommendations are simpler if you want here. The site reduction is recommended only in the high-risk patients and not in low-risk patients. And both hydroxyurea as well as interferon alpha are recommended as first-line therapy, whereas there is no agreement about the use of anagrelide as first-line therapy. But anagrelide and recombinant interferon are again can be used as second-line therapy. Aspirin should be used in all high-risk patients, whereas only in the patients in the low risk or intermediate risk with the age is superior to 60 years in cases of cardiovascular risk factors of the mutation of the JAK2 that we know is approximately present in 50% of the cases. Now, moving to myelofibrosis, these are the more recent criteria established from the WHO 2016, which have been totally taken also by the European Leukemia Net Board. And you may see that concerning molecular markers, it's recommended to perform, of course, the detection of the JAK2, the caroteculin, or the MPL mutations, the 3 mutations, whereas the other mutations, in particular mutations of the genes, of these genes, which are associated, as we will see, with the poor prognosis, are recommended only just to establish the clonality of the disease. And this probably is a limitation because we have more and more data nowadays showing that these are very important molecular markers which are able, indeed, I would say, together with the traditional scores that we are using to establish the risk in myelofibrosis, primary myelofibrosis, which are the IPSS as well as the dynamic IPSS during the follow-up. Indeed, we know that if it's true that these triple negative cases, which are not positive for any of the driver mutations that we can detect in myelofibrosis, are the worst in terms of prognosis, it's also true that these other mutations are independent markers of a bad prognosis. And this in terms of considering all the cases of myelofibrosis, as well also in particular in the low-risk intermediate 1 myelofibrosis. So I think that is useful. It will become more and more in clinical practice used the detection of these other mutations. And now what is probably we will face in the future is a change in the way in which we will be able to establish the risk in myelofibrosis. And you see that in this proposal of the MySEC primary myelofibrosis scoring system, indeed also some molecular markers are introduced. In particular, the caroteculin unmutated genotype is scoring with 2 points, which is a quite high contribution to the scoring system. Now, what about the treatment? The treatment in myelofibrosis, if you have a low-risk myelofibrosis characterized by anemia, in particular if the hemoglobin level is below 10 gram percent, you may see that erythropoietic stimulating agents as well as immunomodulators may be recommended, may be used, in particular lenalidomide in case of the presence of a 5q mutation. For cases which are showing a splenomegaly, so they are already considered intermediate 1 or intermediate 2 and high-risk cases, you may see that indeed Ruxolitinib is becoming the main player, both in the intermediate 2 and high-risk cases as a first line. And you may see that in case also intermediate 1 risk, if these patients are highly symptomatic of they show splenomegaly. And in all the other cases, you can use hydroxyurea and to leave Ruxolitinib as second-line therapy. It's very important, the chapter concerning allogeneic stem cell transplant. You may see that here, intermediate 2 and the high-risk patients are considered for transplant. For intermediate 1, patients who have problems, we say, these are the problems which are, they are transfusion-dependent patients, they are refractory to the therapy, they have peripheral blast, more than 2%, and adverse cytogenetics. We didn't talk about adverse cytogenetics, but it's also an important aspect to be considered. Splenectomy in case of drug refractory symptomatic splenomegaly. And of course, as I told you, Ruxolitinib efficacy is genotype independent. This is a very important point. So we have to consider the clinical aspects, not the genotype, because all genotypes are responding. And we know that once established, however, it's probably of little value to continue to monitor the amount for the presence, at least at the moment, of the allelic burden, because this doesn't change so much during the Ruxolitinib therapy. And of course, it's very important, the indication for the allogeneic stem cell transplant. And you see that here there is a European bone marrow transplant and European Leukemia Net consensus, which has been published 2-3 years ago, you may see that low-risk level should not undergo allogeneic stem cell transplant. Intermediate one is the most, I would say, critical group in which the age less than 65 years should be considered for allogeneic stem cell transplant, if they are, what we have seen that those cases who can also benefit of ruxolitinib therapy, and we have seen in particular now if they have adverse cytogenetics, so triple negative or in particular positive for SLX1. So all patients, by contrast, intermediate or high-risk disease according to the different scoring system, and less than 70 years should be considered potential candidates for allogeneic stem cell transplant. And unfortunately, for the moment, as we have seen from Jorge before, this ruxolitinib is the only JAK2 inhibitor that is available, and therefore, although there are many investigational studies ongoing, we have unfortunately to know that after failure of ruxolitinib, indeed the prognosis is very, very bad, and therefore why it's important to move to transplant. These are the new JAK2 inhibitors which have been already told us by Jorge, and therefore from the clinical point of view, the possible approach to myelofibrosis in the follow-up strategy, and we have mutations and cytogenetics are very useful for disease stratification, as well as in primary myelofibrosis, and in general, triple negative status or more other types of mutations may identify patients in the higher risk, in particular the ASXL1 group, and the decision on conventional treatments is mainly genotype independent, as I told you, and the decision on allo stem cell transplant might be genotype targeted. So they are important to know if the patient is a high risk of progression, and therefore they need to definitely move. So I wanted to thank in particular Francesco Passamonti, who was my mentor for this presentation. Thank you very much. Questions? Thank you. If we not